Okay.
If you would, to begin, if you would please state your name and then spell it for me.
Tough questions. Michael Miller, Michael. Last name is Miller, Miller.
And can you, would you tell us where you work and what your title is?
You betcha. Primary Care Partners in Grand Junction, Colorado, and I'm the IT director.
Could you describe your average day for job duties, your job description, basically? And this is pre-pandemic.
So I oversee all information technology related aspects of everything here at Primary Care Partners. I've been here for about 20 years now. Everything from budgetary to staff to implementations of our electronic health record system to accounting systems to our virtual server deployment to our network to our phone system, pretty much security, the whole pretty much gamut of IT computer related items. We have about 5 staff members here in the building. And then we have 4 locations here in Grand Junction, about 75 providers at this point. That includes physicians and mid-levels, about 310 staff members, I think.
Wow.
We've grown over the years for sure.
Where are these, so you're not all in one facility, you said, where your office is located?
So we have one here in Grand Junction, 3150 North 12th Street. Then we have one over on Wellington off of 7th Street. And then we have 2 out in Fruita, like in the Cocopelli Shopping Center. We have a pediatrics and we have a family practice out there.
And you said you'd been there 20 years. So you've
yes,
really
correct.
been able to grow with the organization.
Correct, Nicole. So basically, I was hired to start the IT department and start our first endeavor was the first electronic health record system. And back when I was hired, we had like 1 server, a couple computers. So it was kind of to build it and then kind of evolve it from there.
Wow. Tell me about what you're doing today.
So, like you said, there's post and then post-pandemic and pre-pandemic. So really about 6 weeks ago, we shifted a number of aspects from the IT, but the biggest thing for us was the rollout of telehealth. That was the biggest aspect. Was we were trying to understand how our patients were going to, what services they were going to need, and how we could help facilitate that. So we spun up telehealth in honestly about 48 hours. We went through a couple different vendors. It wasn't perfect in that first 48 hours, but it did fill the need. Because let's be honest, there was some serious panic happening at that point. And then we were able to get that in place, and then we kind of evolved it over the next 2 to 3 weeks. And I know, once again, we're going into like what I would consider a phase 3 with some things opening here in Mesa County, but it is still pretty heavy for that telehealth at this point. From IT aspect, we changed how we do some things. Staff are no longer really allowed up on the clinical floors. If they do full masks, that type of thing. We did go through a major upgrade in which we did have to touch, the providers' laptops. And I had, full masks on for each of my staff members, wearing gloves, just because we couldn't take a chance. But really, with a staff of 5, we were able to be pretty contained in our little IT area. So overall, the biggest thing for IT-wise has been the insertion of the telehealth into the daily routine for us. Other than that, it's been, and then introducing remote working, which we already had in place anyway. So, that was really nothing big. A few more people here and there, but hopefully that answers your question.
Yeah. So For people who don't know, can you describe what telehealth is and what it means for providers and their patients?
Absolutely. So telehealth, there's a lot of different names out there. There's telehealth, there's virtual medicine, telemedicine. In essence, it's basically a capability for a provider, a healthcare professional, to be able to connect with their patient. And in most circles, telehealth includes video and audio. You can still do medicine via, a chat or email or even just a telephone, but really the telehealth is video and audio. It's really that simple. And there are a number of HIPAA requirements encrypted and different aspects. I won't go into that, but you have to use a platform that is HIPAA certified and has that encryption level. But the biggest thing is so that the provider can see the patient. And sometimes the visit can be, chronic med condition follow-up to make sure, you're working, you're taking your meds and you're doing your daily therapy that you need to do. But on the flip side, it might be a mom with 3 kids and they don't want to come into the office because of the COVID related. And hey, I got a pink eye, and then the little brother might have it. And we've heard appointments of mom, taking the phone and showing the pink eye, and the doctor going, "Yep, you got pink eye," and prescribing. It's not only a convenience for our patients, but it's also a safety measure for our patients. So, and
Go ahead.
so, so you kept talking about the pre and post pandemic. So we really did not have telehealth before this. We had talked about it years and years about it, but the biggest thing was reimbursement. How are we going to get reimbursed for this? And a lot of the payers, including Medicare and Medicaid, had never clarified that. Well, all of a sudden, with this pandemic, it was do whatever you can, and we'll figure out the reimbursement later. So it really opened up the ability, and it also removed some of the barriers of our physicians not wanting to use it.
Mm-hmm.
You have to, if you want to practice medicine, and we've got to do our part to keep patients out of the ER instead of a patient going into the ER for, hey, I got a headache and my general medical care. We need to keep them coming to our clinic. We need to keep a hold of our chronic disease management and keep them out of the ER, keep them here, but also protect our patients, in which if you're chronic disease, you don't need to be coming in this building anyway. Yeah, our building's clean. Yeah, we were taking precautions, taking temperatures at the door. Our respiratory clinic was separate. But if you don't have to come in, and we can provide that medical care outside the building, let's, have a benefit for everybody. Plus, with the stay-at-home orders, you're really also kind of following the protocols too. So
That's awesome. How did you select a telehealth company?
So that's a good question. We had a few vendors that we had looked at over the years. And some of those vendors, there was each that had benefits and, pros and cons. But the biggest thing that we were looking at is usability and scalability. So how easy was it for our patients to be able to connect? That was number one. Number two is, everybody was trying to get telehealth going. We're not the only clinic. You had tons of clinics trying to do telehealth. Then you had the school district everybody was spinning up their virtual classrooms. Everybody was doing remote working. So who had the capability, the scalability of bandwidth and ability to handle an onslaught of us, but also clinics from around the country and the state. So really what sold it for us was the easeability for a patient to connect. That's what we went with, was this is the easiest thing. The vendor we went with, they had the necessary encryption and security levels. That was taken care of. And then second, we could send a text, the back office staff, the nurse, the front office, the provider, whoever could send a text to a patient. And let's be honest, most people know more about smartphones than a computer.
Mm-hmm.
And so it was a text. It was a simple click, whether it was Apple or Android, and it spun up their access, and it was off and running. So that's really the route we went.
That's awesome.
versus trying to figure out some other platform. So
Yeah, I was wondering if it was like in a patient portal and people have to log in and remember a password and then try to who I pick, and it could be very complicated.
So you nailed it there, Nicole. So we do have our patient portal, and there is one of our vendors. You would have had to have a patient portal. You would have then had to log in. You would have to go through the enrollment process and all that. And it was too cumbersome to spin this up quick. And to be honest, we're dealing with patient population of, maybe a mom or a teenager to that 85-year-old person and someone in between. And let's be honest, most of the grandparents know more about their iPhone than, people in their 40s and 50s, because that's what they use to communicate with their grandkids. It was in that middle place that we were having problems with. Yeah. So we just went with no username, no password. Here's a text, click on a link, you're off and running.
That is awesome. Do you think, what do you think the the future of healthcare will look like post-pandemic? I know that we're like come down off of our first peak, right? I feel like right. Anyway, and we don't really know, will there be more spikes? I've read up a little bit about the Spanish flu, and will there be another outbreak, or blah blah blah. And I know we can't tell, but do you have any ideas about the future of healthcare, and will this continue for your organization?
So I'm not clinical. I can't speak to how people are going to, the way this pandemic is going to go. From our aspect, we are planning on everything we've learned. We're going to have what we call, basically, we had a pandemic plan before, but it changed quickly. So we're making a secondary pandemic plan. So if there is another, let's call it a flare-up, we have the ability to basically go back into this protected mode again, spin up everything we did, but with less effort, and then hopefully even streamline it even more. So we have a secondary pandemic plan. That's the first part of the question. The second part is ongoing healthcare, whether it's pandemic happens again. I believe that you're going to see a hybrid model, at least for us, a hybrid model in which, patients still need to come in this building. You still have to have the touchy feel. I don't know, that's not very medical to say that, but you still need the touchy feel. I mean, there's just certain things you can't do virtually or via telemedicine.
A physical examination of the patient from time to time, sure.
You got it. And some people and some patients just don't want telehealth. They want that personal relationship with their provider. They want to come in and talk. They want that one-on-one. The telehealth, though, but let's be honest, it provides a convenience. And you've lived here your entire life too, but in Western Colorado, we have patients in Colbert. They don't want to drive down here because they have a sinusitis. They want to fire up the telehealth and talk to the provider, or even a mom out in Fruita. I mean, my family yesterday had a 9:00 appointment, and it was easier instead of the middle of teaching and doing everything, all of the online thing, fired up and go, yeah, you do have an ear infection. Sure enough. Come on, here's an antibiotic, because he had a history of it. I mean, it's not like they looked in his ear or anything, but, so there's that. I think it's going to be that hybrid model. We are also getting ready to roll out what we call remote patient monitoring. And it's right now, it's not official. We haven't rolled it out. But what it is we will help patients get certain devices, blood cuffs, scales, hemoglobin A1C, diabetic type of things, in which then they can be at home. They do it daily, and we want daily reports. What was your weight? What was your blood pressure, hypertension? And then these devices then report this back via internet, via Bluetooth, and it goes into a console, and then we can track those patients over time and have those logs. And then we can then do the telehealth with them to say, okay, you look like you spiked. What happened here? Do the nutrition through that way, but then that I think it's every 90 days. Don't quote me on that. Every 90 days, then you come in and you do that, high touch, high feel presence within the office. So I think that's what we're seeing. To be honest, there's a lot of markets that are bigger than us. I mean, they've been doing this telehealth stuff for years. One of our partners that we, work well with in California, they have over 1,000 telehealth visits a day in Los Angeles. I mean, are we behind the times? I don't know, probably not. It was more, you got to look at the market you're in, and I don't want to say it's a positive. That's not at all what I'm saying about this pandemic, because
there are a lot of things to come out of it, I think.
Yeah. And one of them was helping bring telehealth mainstream for us in our market. And I think it's just, once again, it goes back to that. Afterwards, I think it's going to be more of a convenience, I think is the way to look at it. Just like, anything that you can do from your house, whether it's your online grocery shopping, I think that's, more people embraced it too.
Mm-hmm. Well,
that was a long answer, Nicole, sorry.
Well, it's perfect. I think that, and I don't know if this is true, can providers see more, can they see more patients a day?
That's one thing some clinics might use it that way. I can say honestly, we are not at this point. If a provider sees, 20 patients a day, the way they're doing it is they're actually scheduling that visit on their schedule, just like if it was in. And if it's an acute visit, it's still 15 minutes. If it's a chronic disease med check, it's 20 minutes. If it's just a 5-minute follow-up to say, hey, how did that work for you? It's still 5 minutes. That's our current model. Now, we are looking at potentially doing a on-demand kind of deal. Wow. And I don't know how else to describe it, but, so we have our after-hours clinic, right? Docs on call, or you have some, this a la carte service where, hey, I necessarily can't see my provider, but I just have a medical question, a medical thing I want to talk about. You have a provider, whether it's a mid-level or physician, just sitting there, and you come in, you sit in the waiting room for, virtual waiting room for 5 minutes, and boom, they answer your questions and you move on. I mean, that's really no different than a walk-in urgent clinic, which we're doing now anyways. So I keep saying non-urgent. Let me clarify that.
Non-urgent, yes.
So, yeah, let me clarify that. Yeah. So I think that's one thing we're talking about. We haven't any plans to implement at this point, but
perhaps in the future.
Yep.
I would imagine, you don't have to worry about traffic or patients being late or someone, pushing back your schedule throughout the day.
And you're absolutely right.
He is clicking a link on a text.
Yep.
But then I wonder about our rural areas and their internet service and connectivity, and if that might be an issue.
That's a very good point. So as I alluded to earlier with everybody, the online learning and the remote workers and other people doing the Zoom meetings and the WebExes left and right now, there has been some bandwidth limitation, especially in Western Colorado. The Verizon cell phone is a big carrier here. Those networks have been saturated. At 9 o'clock in the morning, those first appointments, the video is, iffy. The audio is iffy. So we have seen some problems with that. That has definitely subsided in the last couple, I'd say week and a half. So I don't know if they've added more bandwidth or the demand went down, but I know we did have to add additional bandwidth to our building as a whole.
Explain to me what that means exactly.
What bandwidth is?
Yeah.
Fair enough. So bandwidth is, you have your home connection, right? And bandwidth is the amount of data that your internet brings in, right? So if you're at home and you have, or you're at home and you have, people say, well, I've got 50 megs. That's how much you receive up and down. And on that internet, you can do your streaming, your Netflix, your music, your computer internet, your people looking at their Facebook, Amazon, that all comes across that. And with video has a higher bandwidth capability and it needs more. Now, most have smart technology, which is called compression, so it knows when to reduce based off limited bandwidth. And in Western Colorado, we don't have the same bandwidth capability as they do in Denver, right? And plus, it's more expensive, especially for enterprise business level. So bandwidth is limited in certain areas, like in Grand Junction City, you're going to get better. Out where I live, you can only get wireless. I mean, so there is no CenturyLink, there's no Spectrum, there's no Comcast, right? So you're right, Nicole, that's a very good call. Certain areas of this, bandwidth is going to be a problem. So then they rely on their cell phone. So then there's the cell phone capability. And everybody's talking about 5G versus 4G. I'm not going to go into that description, but most people here have 4G. Well, everybody's using their 4G to stream and do everything in densely populated areas. Like in the city of Grand Junction, you have more antennas, better throughput. Mm-hmm. Outside, those areas where you only have, everybody's done it. You're driving down the interstate. Well, I've got service, so I don't. I only got one bar, I got 2 bars. I mean, that affects everybody. So
I see. Thank you.
No worries.
So did I send you the questions?
Yes.
Did you look them over? There is a section about leadership and compassion, and it's a little touchy-feely, kind of personal to you. And if you don't mind, I was wondering if you'd talk a little bit about that. How have you sort of maintained or had the opportunity to express or see compassion in your workplace during this time?
So,
I can imagine it would be hard to go through an upgrade, like you were talking about, where all your small team of 5 has to touch so many.
So, I guess, Nicole, I looked at it from 2 aspects. There's the clinical side, which what we do is for our patients. I mean, that's the first thing we do, but then you have to look internally in the business as well. So patient-wise, we were able to give them the tools they need, feel safe, so they didn't have to come in the building. That was the first thing that you really needed to do. If we can keep you out, get you stay at home, that's the first thing. You've heard stories of elderly couples that, they had problems with that first time getting on the phone and or on the telehealth, and our staff members, our providers, work with them to get them on that device. And then the thanks that you've heard is, oh, I didn't want to come in even though my husband's so sick. He has this, and this, but we needed to talk to you. So, I mean, that's the first stories you heard and that made you feel good knowing you helped deliver that tool that somebody was able to use. But then you're also proud of your colleagues and the fact that they took that extra time and effort to help that person get connected, and they didn't, frustrated. And as we all know, you can get sometimes with trying to explain technology. And on that secondary side, our company as a whole, made it very clear to us as an IT staff, what we're asking is intense and impossible, and any tools you need to do it, but they explained why we were doing it. It wasn't just an exercise in futility. It was, here's the benefit, why we're doing it, and let's make this happen. And sometimes that type of leadership and guidance goes a long ways. It's not just go out and do it because you're told. And obviously I'm biased because I've been here 20 years and I've bought into this corporate structure. So I think that touchy-feely moment was you knew what you were doing, and you can watch the news at home and you can look at it, and it necessarily wasn't an interaction with anybody, but we we're not essential, as in we're not an ER worker, or those horror stories you hear in New York or even in Denver of people being isolated and not being able to be with their loved ones, but we're helping keep that rise down by providing medical care, and people aren't going to the hospital if they don't need to truly be there. So I think that was kind of comforting to know that what you're doing. And, you know, to be honest, it also helped. I mean, my wife works 3 offices down the hall from me, so she's IT too, so we're here all the time together anyway. So it really, we were in a position, so we weren't separated, so we just worked through these hours and did it. So it actually, small story, I think that was kind of fun because we're here together, and it wasn't any really change for us. We had our support system at home and here in the office. So
I did not
I don't know if that answers your question. So there you go.
Oh, that's awesome. It must be great to be able to work with your spouse.
Certain days.
You know what I mean.
Yeah.
Is there anything that you'd like to talk about that you've learned about yourself or about others or your organization during this time?
No, I think, I really kind of covered that with, what we were trying to do is do our part, make sure we provided that care and kept them out of the hospital system. Company-wise, it was interesting to see, I'm not going to name any names, but it was interesting to see some of our providers that just don't enjoy technology really throw away the stubbornness, I guess is the word, and just be like, "Yep, we'll figure it out. Let's move forward." So it was really fun to see that. So
I can imagine that would be fun to see. I have a story from one of our nurse instructors who started a remote class and worked with a gal. She'd been out of the workforce for a while and just getting back in to figure out email, and then to figure out Zoom, and then to learn how to take a test and watch videos. And, by the end of it, the woman started, she didn't know how to text. And by the end of it, she was sending emails.
That is great.
It felt great. Like she was like, I can totally do I'm not sure, medical records where they log in medications. I think it's called Mars. And she said, I'm not intimidated by that anymore. So
that's incredible.
That's
fun.
And imagine the patience of our educator to take someone from that level and that quickly,
Well, but see, it's two-sided, and you said that very eloquently. It's, number one, that person who might have the phobia of technology is willing to embrace it. Now, on the other side, there's that person that has the patience that, let's be honest, it's a lot of repeat and redo and repeat and redo to develop that muscle memory. So you're right. It's a very two-sided coin.
Yeah, I was very happy to hear about that.
Absolutely.
It sounds like you've been working a lot of hours then, especially in the initial phases of this. What do you think the most difficult adjustment to your life in general has been due to COVID?
Honestly, inside the office, it's a little different not being able to interact with the other staff members, but up on the clinical floor. So, that was a little different, but people say IT isn't social anyway, so that fits our mold. But probably on the personal level, not being able to see my parents per se, the weekends, hanging out with the friends, the family, having that weekend beverage, I think that was probably. And then on a selfish note, just not having any sports on, that's kind of my stress relief, is watching different sports. So I know that sounds kind of selfish with the bigger things in the world happening, but yeah.
So how have you then transitioned? What do you do now instead of those things to decompress after work?
A lot of yard work. My wife and I spend a lot of time at Lake Powell, so we've been hopefully planning trips and figuring that out if they ever reopen Lake Powell. But
Yeah.
cleaning the boat, waxing, all that stuff and anticipation. But a lot of hikes around the house. I mean, try not to go where it's massively populated, but
Yeah. This is great talking to you. I sure appreciate your help. And your perspective is not one that we've had, or that I think we even, when the concept was developed at our sister AHEC, something that they hadn't even thought about. So I appreciate your time, and you really brought some perspective that we couldn't get anywhere else. So